Welcome to session 13 of the World Sepsis Congress. My name is Dr. Ron Daniels. I'm an intensive care physician in the UK. I'm the founder and chief medical officer of the UK Sepsis Trust and vice president of the Global Sepsis Alliance. And it's my absolute delight to be hosting this session today. But before we start, I need to thank our sponsors, bioMérieux, Menarini, and Sobi for their valued support to this Congress. So this is around emergency, critical, and operative care pathways in maternal and child health. That's the theme for this session. And who better to start us off in this than Teri Reynolds from the World Health Organization. And Teri's going to tell us what the ECO continuum is and the importance of effective integration to address sepsis. Now, Teri's been very active within WHO for a long time, and she now leads integrated services and models of care in the Department of Performance, Financing and Delivery at the World Health Organization headquarters in Geneva. So this is about bringing together WHO's work on integrated delivery channels, so that primary care, emergency care, critical care and operative care, to deliver cross-cutting efforts on effective service organization and patient and people's movement, and therefore is involved in leadership on the sepsis and trauma care. So Teri's previously led the emergency and trauma care, has worked with COVID-19 pandemic coordinating efforts, and this is all following qualification from the University of California in San Francisco with a master's in global health. So she's previously been professor and director of global health, as well as working with the scientific committee in the African Federation for Emergency Medicine, and has worked in Tanzania, and so on and so forth. So she's got a huge wealth of experience in this space. So Teri, thank you so much for joining us, and please tell us your perspective on the ECO continuum.
Thank you very much, Ron. It's a pleasure to be here with everyone today. This is a meeting that I returned to over the years and a group of people that I work with throughout the year. So it's really always a great pleasure to be here. I'm here to talk to you today. You know, we all share an investment in sepsis and thinking about how to recognize, how to respond, how to prevent. And I'm here to talk to you about a broader concept that really can support the work that we do for sepsis and really is essential to getting people with sepsis the care that they need. So I lead a team called Integrated Services and Models of Care. And many of you know WHO. I have no specific conflict of interest to report. Many of you know WHO and the way that it works, and we tend to think in terms of system components at the same time that we try to address specific health issues that individuals have. So when we talk about the concept of ECO, integrated ECO, and I'll tell you a little bit more about where it comes from and how we use it, but really what's intended is a continuum of services from the community to the clinic to the hospital. And it's very important. It's not an E plus a C plus an O. It's one thing, and it really can't be easily separated. And that matters a lot because the point is that different countries use different words for pieces of this continuum. And different people address it in different ways, but it is only effectively addressed as a singular continuum. So this is, again, not a series of programs brought together, but an entity that is in itself inseparable if we're to engage with it effectively. So one of the advantages of treating this continuum like a continuum, like what it is that we remove unnecessary silos, improve efficiency, improve effectiveness, but also reap economies of both scope and scale. And we bring shared assets to a range of disease and life course programs. Life course programming, disease programming is very effective. It's not an evil in the system. However, there are ways that we can invest in health systems that takes a singular investment and multiplies its benefits. So very quickly, we're talking about this in the frame of a resolution that many of you know well, the Integrated ECO resolution from a couple of years ago, and more recently, the associated global strategy. This was just passed by the executive board in February and will go to World Health Assembly next month in May, and will be quite an opportunity for advocacy for all of the work that you do. Um, the interesting element about the global strategy is it's organized by strategic objectives. You can see those here. It's a number of different entry points to the integrated eco-continuum. I'm going to focus on number 2 for a minute because I was asked to talk really about how this continuum of care works to deliver for people with sepsis. So a model of care can sound like a very abstract term, and it's used in a lot of ways by a lot of people. What we mean by it at WHO, and what I find very valuable to help us focus on this middle level, this meso level of organization, is the definition from the PHC operational framework. A model of care is a conceptualization of how services should be delivered. This includes processes of care, organization of providers, management of services, and it's really about defined roles and responsibilities for platforms, but also for providers, and that those are organized along care pathways that reflect and are oriented to the needs and desires of people. And the strategic choices that are made, these can be implicit or explicit, but they are made. Make no mistake, every system has one or more models of care, whether they do that explicitly or not. And those establish a pathway, and that pathway creates a channel for people's movement, and it in many, many ways controls what happens to people in the health system. And that can be for better if it is an intentionally and well-designed pathway, or worse. So there are a lot of ways to do this badly, and this is not something that any health system can get out of. We have to make choices about how the services are organized and where we place our resources that are available in a health system. So we tend to address this across 3 levels, and I'm not going to go into a lot of detail, but I do want to tell you how what is a powerful way to help health systems deliver for people with sepsis. So how do we operationalize this component of models of care? Because make no mistake, the model of care controls as much as health worker skills, as much as the availability of diagnostics and therapeutics. The model of care controls whether or not people with sepsis get the care that they need. So the first part of a model of care is the services that have been prioritized. We do a lot of work on UHC planning, and this is the specific UHC planning platform. One of the things we've accomplished over the last couple of years is having comprehensive services for sepsis within that, so that when countries plan and prioritize services, the services for sepsis are available. We have a dedicated pathway to care for sepsis so that health systems can look at whether they have the component functions that are needed to deliver care for people with sepsis. And finally, there's a range of tools at the level of delivery. What you see here is our sepsis module on our WHO clinical registry to allow data collection, identification of gaps in care, audit filters, and corrective actions. And then with that, I put one of the really key corrective actions, clinical decision support, to systematically manage people with sepsis at the early part of the system. So one of the things we know is that simple intervention very early in the continuum is extremely powerful. It has knock-on effects all the way across the continuum. Many of you know some of the tools you see here. These are components of the WHO Acute Care Toolkit. And Melissa is going to speak later and tell you a lot more about these and how they look and work in a facility when they're implemented. But I wanted to show you just for a minute why we care about this early intervention. So this is around a WHO program called Basic Emergency Care. This is the mortality reduction that we got across first level hospitals in Africa and Asia. The reason I show you this with these conditions, of course, the ones with the pneumonia, the ones who are dying, are largely doing so through a pathway of sepsis. Many of those who die from injury or diarrhea, the same thing. But one intervention that delivers across the health system, this is a good picture of the power of integration. Also, we have a specific focus this year in the conference on mothers and children. This was a study database of about 35,000 patients. And more than a quarter of them were children under 18. Most of those were under 5. And as you can see, the mortality reduction was even higher in these groups. Again, simple intervention at the front of the system. I'm going to show you very quickly now just a couple of slides on things we're doing. This toolkit that I mentioned, Incredibly simple, very low cost, no new input of material resources required. It's been implemented in more than 100 countries, but now we're looking at what it would mean to really take that to scale. So thanks to the support from the WHO Foundation and a donor consortium called Lifeline, from which Laerdal Global Health made a foundational investment, we are now looking at what it means to take this all the way to scale in right now 4 and soon to be 5 African countries. We're doing a lot of this work with partners from the Acute Care Action Network. So I wanted to share this, and I'll give you a QR code at the end for that. But this is really the network of many organizations. GSA is very strongly part of this, and we welcome any of you who'd like to get involved. Also to be released soon is the part 1 of our formal WHO guidelines on the clinical management of sepsis, and upcoming in association with the resolution and the global strategy I mentioned, we will have a global status report on ECO, within which will be a separate extracted global status report on care of people with sepsis. As you know, we've had one on prevention and epidemiology before, but we're now working towards one on the care of those with sepsis. This is the QR code for the Acute Care Action Network for those of you interested, and a program email where you can reach us at any time. Thank you very much.
Thanks so much, Teri, for that extremely helpful overview of ECO and what it means in this context. A reminder to those listening that these are short presentations, meaning we will have a panel discussion. We would love to hear your questions. Just put them in the chat on the YouTube channel and we will look at them and we'll get as many of your questions to the channel as we can. So our next speaker is Professor David Lissauer. He's Professor of Global Maternal and Fetal Health and Head of Department at the University of Liverpool, as well as being a consultant obstetrician at Liverpool Women's Hospital. Now, I've worked with David in Malawi. I've been there a tiny fraction of the time that David has in the country. We worked together to help develop the FastM maternal sepsis bundle. And David's also worked clinically in Blantyre and Malawi, and he's Deputy Director of the Malawi Liverpool Wellcome Research Programme. And he's got a huge focus on maternal infection and sepsis. And, you know, as chief executive of the APT sepsis program, multi-country, cluster randomized controlled trial of over 400,000 women in Malawi and Uganda, led to significant reductions in mortality and morbidity. So, David, please tell us about how we implement effective community to hospital pathways in maternal sepsis.
Hi, yeah, thanks for the introduction, Ron, and great to be able to give our team's experience of implementing maternal sepsis bundles across community and hospital pathways, particularly in Malawi, as that's the area that I've worked in. So I'll very briefly give an overview of some of this work and wanted to start by setting the context really and the challenges within Malawi. So our team supported the Ministry of Health in Malawi to conduct the last maternal death report, and that demonstrated that around a quarter of all women in Malawi who died, it was due to maternal infections. And there's a well-established maternal death surveillance and response system, and hospital committees review these deaths, and they reviewed over 70% of those mothers who died, and that gives us really critical further information about the factors that were associated with those deaths and what those committees of healthcare providers and managers identified with some really key factors. Most importantly, delays in the patient and family reporting to the facility, delays in commencing treatment, incomplete initial assessment, inadequate monitoring, resuscitation, and even when there were observations, that there were prolonged periods without them being acted upon. If we just drill down into that data, it also reveals something I think really critical as we think about this continuum of care from primary to secondary care. And that's if you focus on those women who died of infections, if that block on the right, actually more than 70% of those women who died actually arrived in the final facility where they passed away already critically ill. and those women were coming both from home in the community and other facilities. So clearly, if we're going to stop this problem, we need to be acting earlier in the pathway and preventing those women already arriving in such an unwell state. We could really learn valuable lessons from listening to women in Malawi tell us about the journeys they had through the healthcare system, where they developed maternal sepsis and severe adverse outcomes. And they really added to those findings of the maternal death surveillance and response report by identifying key issues with their experience of care. So factors such as healthcare worker attitude, behavior, the patients not feeling empowered to express themselves and the problems to healthcare providers, lack of respect in maternity care, and poor psychological support. Those were those women's experiences, alongside challenges they identified that mirrors those that the providers discussed, like delays in early detection and recognition, inadequate capacity around diagnostics, clinical assessment, theatres, wards. So, you know, what to do about this? I think there really are practical, implementable tools now out there, and to highlight the active prevention and treatment of maternal sepsis, which was a large cluster randomized trial that we undertook with the WHO and other partners. And this really demonstrated that we could support healthcare workers with a multi-component intervention that helped them change behavior and achieve 3 key goals. First, improved hand hygiene. Second, infection prevention and treatment according to WHO evidence-based practices. And goal 3, which was early sepsis detection using a structured early warning chart. And then, as Ron mentioned, the FAST-M maternal sepsis bundle. Just to focus a little on goal 3, early sepsis detection was supporting healthcare providers to regularly take observations and trigger action based on simple vital sign threshold, with a red as directed by the decision tool, leading to suspected sepsis and use of the FAST-M bundle, which was fluids, antibiotics, source identification and control, transfer of the woman if required to another facility or to an appropriate place within the facility, and monitoring of the mother and baby if appropriate. And right from the start, when this bundle of care was developed, it was in mind that it shouldn't just be applicable in a secondary care hospital setting, but is also something that we would want to be applied in a primary care clinic, as this is where most women are receiving their care and having babies if they're deemed at low risk. So we now have the opportunity to know that with this simple to implement package, surrounded by a carefully developed implementation approach, we can improve adverse outcomes and reduce the primary outcome of infection-related mortality and severe morbidity. But importantly, the sepsis trial was within district-level hospitals. They had to be able to deliver comprehensive emergency obstetric care, such as having operating theatres. But I really wanted to highlight that this isn't the only place in which we have evidence that the FAST-M bundle can be applied and is feasible to be implemented. So prior to the sepsis trial, work was conducted specifically focused on health centres, which are the primary care providers within Malawi, where a majority of women attend for their antenatal care and deliver if they're deemed at low risk. And I think importantly here, we didn't only implement at the health centres, but we implemented at the hospital and then 4 of their feeding health centres in 3 areas, because the health centres come under the auspices and the authority of the district. And so it's important that they move together and that there's strong communication This was a simple before and after design across these 15 sites, and there were additional tools required to really make this easy to implement in a primary care setting. So, for example, outpatient cards, stickers, additional posters to support providers to take and act on observations taken in women who are not admitted to the facility, and then a real focus on referral, as anyone who's identified at needing additional care would move from these small facilities that are often just staffed by one or a small number of midwives. So, in conclusion, it was feasible to implement across these sites, both the elements where we improved vital sign monitoring and those women who were identified as having a suspected sepsis receiving, for example, appropriate antibiotics within 1 hour. And I think, interestingly, some of the qualitative work we did alongside really supported that within these primary care facilities, it was acceptable, with staff really supporting that this was actually making their lives easier because they knew what they needed to do. It actually was of less effort, and they felt that they were really supporting the mother by making the right decisions. There were barriers, in particular shortages around staff and resource availability, but the implementation strategy had some key enablers like the sepsis champions, task sharing, ensuring that the nurses were empowered to initiate treatment without recourse to clinicians. And this was really something that could be normalized within those primary care health centers. So in conclusion, as we think about how important it is when we implement maternal sepsis bundles and the approaches around those required to change behaviour, that we think not only about the secondary care hospitals, but about what we need to really support women's journeys and improve outcomes across the continuum. So education, empowerment, respectful care, and then tools that can be implemented across primary and secondary care, and thinking about how they work to underpin linkages between facilities in terms of communication, referral pathways, transport, but also recognizing that at the moment, many women are arriving at facilities already critically ill. So we do need to ensure that those women also have improved access to more advanced care. Those in red, just reflecting on how this sepsis bundle needs to fit within the wider health system, integrate horizontally with the other key maternal health conditions, and when implemented on the ground, needs to be seamless and not seen as a siloed vertical program in isolation. So when a provider is visited by a ministry at a quarterly review, they of course aren't only looking at sepsis, but this is integrated across all the key metrics that they'll be reviewing and supporting, and that this is reflects not only the health system, but needs to be cognizant and work within the wider context of communities and societies. And as we seek to try to ensure interventions really apply to where most patients are in the primary care setting, that we, of course, recognise that that's also the place that, especially in rural areas, has least access to staff and resources, and that needs careful consideration. Thanks, Ron.
Thank you so much, David. And just to reiterate, I mean, hugely important work. It was a real privilege to play my tiny part in that in Malawi. There must be questions for Professor Lissauer, because this cross-cutting across the whole healthcare system intervention with demonstrated outcome improvements, must generate some questions. So please pop them in the chat. So we're now going to hear from Prof. Tim Baker around how does essential emergency and critical care support ECO. Tim, as you can read on your screen, is a professor, critical care physician and anesthesiologist in Tanzania. So his positions at Muhimbili University in Tanzania, Karolinska Institute in Sweden, the London School of Hygiene and Tropical Medicine and Queen Mary's in the UK. And Tim has also worked in Malawi. He's got a couple of decades experience in global health systems and critical care research. And he's worked with the WHO, the World Bank, UNICEF, United States Agency for International Development, and many, many others. Tim developed the concept of essential emergency and critical care and is principal investigator on the provision of essential treatments in critical illness projects. He does a lot of consultancy, leads global collaborative research, and I can't think of anyone better to tell us about emergency and critical care supporting ECO.
Thanks so much, Ron, and thanks so much, Teri and David, for fantastic presentations before. It feels a bit intimidating going after you two. I want to just focus a bit on the real foundations, the real basic things within this brilliant new initiative of ECO. And to start with 3 cases to focus our minds of who we're talking about here. The first is Baby Jackson, who's a 2-year-old, comes to a health facility unconscious with a fever. He gets a diagnosis of malaria and sepsis, gets the antimicrobial medication he needs, and is admitted to hospital. Unfortunately, overnight, Baby Jackson changes condition and dies. And then we have Maria, who's a mother, and after giving birth at home, she comes into a health facility also unconscious and febrile, and she gets a diagnosis of sepsis as well. She gets the surgery and the antibiotics she needs, is admitted to the ward, and sadly, Maria also doesn't make it through the night. And the third patient, Michael, not a septic patient, Michael, but he's a motorcycle driver, 25-year-old, comes to hospital after an accident covered in blood. He gets a diagnosis of polytrauma. This facility has a CT scan, can do surgery. He's taken to the ward, and you've seen a pattern emerging here. Unfortunately, Michael doesn't make it through the night. And the question for all of us is, what's happening here in our health facilities? Why did they die? And often we think about areas around issues around the quality of the specialty care they're getting, the pediatric care, the obstetric care, the trauma care. But these cases, what I tried to show is maybe the care was pretty good there. Instead, maybe it was something else. Maybe these patients became critically ill during the night, that their condition changed, and this deterioration was not identified. Or maybe they were identified, but they didn't receive the things that they really needed to save their lives. So this takes us to the concept of critical illness, which I would say is best thought of in a very broad way as any patient, any human who becomes so sick that their life is now in danger. So it's the most severe form of illness. And these patients can be of any age, from newborns to elderly, can be of any specialty and any underlying condition. And critical illness has, unsurprisingly, a very high mortality rate. These patients need care, and this led us to a group around the world to define a concept of essential care of these critically ill patients, essential emergency and critical care, defined as the care that all critically ill patients should receive in all health facilities in the world. So it's kind of a minimum standard of care that all patients really should receive, and could be conceptualized in this pyramid where, as you go up in this picture, care is getting more complex, more costly, and along the bottom is all the different parts of our health services. So emergency units, operating theatres, ICU, wards, and indeed primary healthcare facilities. And the EECC is this foundational bit that goes across all units and is the most basic things, the airway protection, the oxygen, and so on. And building on that, if capability exists, more complex, more costly care can be provided, intermediate care, such as CPAP and vasopressors, and then advanced ICU care up in the pointy bit at the top. A consensus was come to with experts all over the world from very many different settings, different specialties, coming up with the exact content of these things, 40 different clinical processes, things like triage, identifying, using vital signs, providing oxygen and fluids, but not up to the level of these intermediate things such as blood transfusion or CPAP. So ECC was kind of conceptualized, and then it was given some content by this global consensus process. And last year, a large study was done across the African continent, trying to look at several different issues. This was published in The Lancet, and what it found was that 12.5%, so 1 out of 8 patients within African hospitals are critically ill. So the concept that critical illness is quite a minor issue, maybe just isolated to intensive care units, is shown to not be the case. These patients are everywhere. 69%, so 2/3 of them were cared for on general wards, not in ICUs. This really is a large issue that has population health significance. So that's something important for all of us, I think. Of these patients, the middle circle at the bottom there, we looked at what proportion of patients were receiving these basic essential emergency and critical care, and found that more than half of the patients, so 56%, were not receiving this care. So there really is a large unmet need of the basics happening in our hospitals. These patients had a very high mortality rate, so they really were very sick. Interestingly, this is not just a low resource phenomenon. This is truly a global phenomenon. There's studies coming from Sweden, very similar methods from that ACIOS study, finding actually very similar results. So almost half of patients in Swedish general hospital wards were not receiving ECC. They were not getting the airway supported. They were not getting oxygen. They were not getting support for their circulation. So we really have an issue, I think, all over the world with a lack of the basics in critical illness. So we have a problem. We have a lot of critical illness. We have a lack of the basics. Can we build in then ECC in the same way, exactly as Teri and David are talking about, and with their very impressive results? It's all really putting together a comprehensive picture that if we do this foundation of care for very, very sick patients, we will improve outcomes. So ECC is a bit like the guardian of the most foundational part, ensuring that the basics are done. If we ensure this is always done, then we will end up with improved care and outcomes. And some modeling has suggested that 1 million lives could be saved each year. It's very cheap. It's very cost effective, $14 per DALY averted. And it has this equity focus. So it's really making sure that no patient groups are left behind, or it kind of is raising the floor to make sure that we give equitable care to everybody. It's designed for task sharing. It's not only doctors or specialists who can provide this care, it's for the whole team who are managing the critically ill patients. And it leads to our facilities being prepared for any surge of critical illness, which you tend to get in public health emergencies, the pandemic being the classic example. Following the pandemic, we also have all over the world very large initiatives scaling up ICUs, scaling up oxygen production. And if we only provide that care, we will not realize the benefits of those fantastic initiatives unless we also make sure we are giving ECC to our patients. In Tanzania, where I'm based, there's been a large implementation of ECC in the last few years. It started with a policy document. The government published a document saying that all critically ill patients in the country should receive at least ECC. And now a government-led program with support from UNICEF and Muhimbili University has been conducting a multifaceted implementation with a lot of different tools, a lot of training, a lot of introducing these ideas to leaders all the way through the system, different job aids, some of the ones I'm showing you there, doing local data capture and sharing so that the facilities can know what's happening. And a lot of this training is very, very similar to some of the fantastic other trainings that are out there, like the basic emergency care that Teri talked about, or the ETAT that is also promoted by the WHO for children. Some findings that are starting to come out of this ongoing analyses are taking place, but in this implementation, what has been seen is a 31% decline in inpatient deaths in the months after the implementation compared to the same months the year before. And this may be explained by an increase in ECC coverage. The facilities before implementation had a 27% coverage, so 27% of patients were receiving this basic care. And it rose up to 75% afterwards. This maybe in turn can be explained by other explanatory factors. What we saw is knowledge among health workers increased. We saw an availability of resources at the facility level increased, despite no material resources being provided in this program. and a readiness, which meant that the facilities were making sure that bedside the patients, these resources were available and ready to be used for critically ill patients, also increased. So this is like an embedded, integrated implementation program, wide scale across many regions of this country, showing that it really can make a difference to care and potentially to outcomes for patients. So to finish off, what we're conceptualizing is that we have a system in our health facilities and in our health systems built on a bit of an unstable foundation. We're building advanced care. We're trying to do a lot of fantastic things, but this foundational bit of care for critically ill patients, the EECC, is a bit fragile, and if anything happens, that would fall over. And we want to turn our health systems and our health facilities more like this, so everything is based on a very stable foundation. Finally, we know then that critical illness is much more common than thought, and we also know from many other sources that sepsis is also a very large part of this, and we have a substantial unmet need of providing care for these patients. We need to improve care, and as part of that, we really must make sure this foundational part of ECO, which is ECC, is the thing that is focused on first and foremost, and this has a large potential for averting unnecessary deaths. There's a large global movement doing this. The QR code there takes you to the website about this, which now has more than 2,000 members, and we're a proud member of ACAN, together with led by the WHO. Thank you very much.
Thank you so much, Tim. A compelling concept and evidence of benefit. You might just want to have a quick look in the chat at some nice comments coming in. And just a reminder to those listening and watching to please put questions for our experts in the chat. So we're now going to hear about sustainable capacity building for first contact acute care, according to the WHO Basic Emergency Care Program. We're going to hear from Melissa Campos, who's an obstetrician and gynecologist and health professional education specialist, as well as global health expert with significant experience in maternal health, acute care, health system strengthening. Melissa is originally from Mexico, but she now works along with Teri in the Performance, Finance and Delivery Department at the WHO, where she supports global and regional initiatives to strengthen all of this stuff we're talking about, emergency, critical and operative care systems. So she's undertaken technical cooperation with ministries of health, international partners. She's led emergency care systems assessments in many countries and coordinated the implementation of WHO emergency care tools, including BASIC, as just mentioned, and supporting facility-based and pre-hospital, just like David. So getting outside the hospital, which is critically important. Melissa holds a master's in medical education from Harvard Medical School and is very involved in health workforce development. She's also academic director at Ultra Masterclass and developed and directs the certificate program for health professions education at Pan American University. So huge influence both in systems design, implementation, and also in medical education. Melissa, please tell us all about how we build sustainable capacity.
Good morning, good afternoon, good evening, and thank you so much for the invitation. When we talk and think about sepsis, we often think about advanced care or specialized interventions. But as many of you know, and many of my colleagues already said, in many settings, outcomes for sepsis patients are determined a lot earlier. They are really, really determined at the first point of contact with the first provider, when a patient arrives, and when the first person who comes into the patient recognizes the condition and acts quickly. So today I'm going to discuss very quickly how the WHO Basic Emergency Care Program can support that moment and what we are doing to strengthen eco-care at scale. I have no conflicts of interest to declare. And before we go into the details, it is important to recognize what's the scale of the need. And from many, many different studies, we know that more than half of global deaths and 1/3 of disabilities, specifically in middle and low income countries, are from emergency conditions that could be addressed if timely quality emergency care is given. And this translates into a death every 2 seconds, which is extremely relevant for all of us, as many already pointed out. What's important is that these are not necessarily deaths from highly complex conditions, but from acute illnesses and injury that require timely recognition and timely and early intervention. So we have all these interventions. We have antibiotics, we have medicines, we have the means to save these patients, but intervention, the effectiveness of these interventions decreases with every minute of delay. So a timely first contact and an early intervention is not only essential, but actually amplifies the impact of the rest of the ecosystem in the continuum of care. So the basic emergency care program was designed to address exactly this gap. What happens the first moment a patient goes into an emergency unit or with a healthcare provider outside? The BEC course is an open access course for first contact health workers, and it focuses on a systematic approach on how to recognize and manage life-threatening syndromes even before knowing what's the specific diagnosis. It has 5 modules, and it's structured around several important conditions that respond to how people are presenting into when they are, whether it's injured or acutely ill, like it's in sepsis. And this is critical for conditions like sepsis, where early action and early recognition is critical. So BEC is focused on strengthening clinical reasoning, knowledge, and also practical skills. So if you are not familiar yet with the basic emergency care course, I have this QR code that can take you directly to the page. This course has been out and implemented in many, many countries around the world. I may be wrong, but I think it's more than 80 countries, like Teri mentioned. And we have had a lot of experience now. And all this experience of implementing the BEC course took us to learning. So we needed this, has been classically delivered as a 5-day course, but we needed to have a way of taking health workers out of their workplace for a less amount of time. So WHO developed the BEC hybrid course as a means to deliver these through a combination of a self-paced online program along with a short in-person face-to-face interactive training called practical skills training. So this reduces significantly the time away from clinical duties while maintains learning and hands-on skills needed for managing this patient. So from a systems perspective, this makes the large-scale implementation of the BEC course a lot more feasible across facilities and countries. But we know that a single training at a single intervention at a time may not be enough for health workers to keep these skills and to keep this knowledge. We know that skills decay over time, that people forget what they learned in one-time courses. So this is why we developed BEC S13 to complement the BEC learning as a longitudinal workplace learning that is embedded into the workplace culture, including team simulation sessions and individual skills practice on the right. So these two are the most important elements of this longitudinal workplace learning, along with a few enablers that are very important for this S3 intervention to be embedded into the culture and be adopted by the health providers in the whole hospital, and to be something that is carried on over time and not only a single training. So I'm just going to describe what happens at each one of these two modalities of practice. At the team level, simulation sessions are very short, are grounded in scenarios. We call it the BEC practical case scenarios. And they are planned to build confidence, link practical skills to clinical reasoning, and also strengthen teamwork and reflection on what happens, what patients they saw this week, what could they have done better, and recognize how these practices can help them improve their clinical practice and their clinical decisions over time. So this is critical in acute care situations where coordination, practice, and timely response really changes with these team simulation exercises. The second part of S3 are individual skill sessions that are short and very focused and are designed specifically to maintain the technical competence or the skill competence. So they are self-directed, and the idea is that they can be integrated into their workflow. They can be done 10 minutes or 20 minutes after or before their shift. And it can be done either individually or with one colleague without any further planning. They just have a space where they have these materials and mannequins and anything they need. So the S3 provides a space and an opportunity for them to come and learn and practice whenever they need it. And why we think this is important for sepsis, particularly women, newborns, and children, because we know that the first 30 to 60 minutes are really important and sadly often belong to non-specialist teams. So they are the ones recognizing deterioration, stabilizing patient, and starting interventions that are directed towards saving life. So these moments are specifically the gap that BEC is designed to work on and train these providers, building confidence, strengthening teamwork, especially with this longitudinal workplace intervention. We are calling this, and we are using a low dose, high frequency approach. So we want them to be practicing as much as possible in low dose, because this has proven benefit for long-term learning and retention. So how are we doing in implementing at scale? Well, we are moving towards large-scale implementation of this model. We are doing active plans and about to start expansion in 4 African countries in 846 facilities. And there are other plans of expanding this work in Asia and the Americas in the future. This has a system impact because it contributes to strengthen eco capacity at the facility level, enables consistent recognition and early response. This creates a scalable and sustainable workforce capacity building model, and we promote the integration across the continuum of care of all this knowledge. So this is really an opportunity for all of us, and this BEC hybrid plus the BEC S3 practice can be a scalable capacity building mechanism that, if done in partnership with governments or stakeholders, wherever you are, has the potential of acting within these first 30 to 60 minutes of critical illness and sepsis recognition. So over to my last slide, which is just a reflection on how sepsis survival is not determined by a single intervention or by an antibiotic, but it's just determined by the whole system, but by what happens in the beginning of it and in all the continuum of care from the community to the hospital. And this continuum begins with the first provider that sees the patient, the first decision that's made, and BEC is really planned for this. So if you're looking forward to know any additional information about the basic emergency care course or the whole toolkit that Teri Reynolds mentioned earlier, you can write to emergencycare@who.int. And thank you for the invitation again.
Thank you so much, Melissa. And you too can look to the YouTube chat where you will also see some very strong congratulations. We love to see congratulations. We'd also like to see some questions in the YouTube chat, if you don't mind. Otherwise, at the end of the meeting, you will simply hear the questions that I would like to know the answers to, and they might be different to your questions. So I'm now going to introduce Professor Andrew Argent. He's going to talk about building reliable end-to-end healthcare for children with sepsis. Now, Andrew's been working in critical care in Cape Town. I think the bio says for over 30 years. I checked, Andrew, and I believe it's 38 years from your video when you were awarded the Cape Town University Distinguished Teacher Award. And Andrew now directs Africa's largest pediatric intensive care unit, or at least did until 2019. He's now retired, but he's chair of the African Sepsis Alliance and past president of the World Federation of Pediatric Intensive Care and Critical Care Societies. So he's still heavily involved in developing clinical approaches to the recognition and management of sepsis in children, particularly in critically ill children with sepsis. And as I've alluded to with this award from the University of Cape Town, is passionately interested in education and training more junior health workers. So, Andrew, please tell us about building reliable end-to-end healthcare for children.
Well, David, thank you very much for that very generous introduction, and thank you for the opportunity to present some of this work in this setting. I think for me, one of the issues that I want to highlight is that when you talk about caring for sepsis, you really need to talk about care from neonates through to old age, and you also need to talk about care from the home through the whole health system and back into the home. And part of that is underpinned by the fact that in many African settings, something like half the mortality related to sepsis happens after children have been discharged home. And so I want to highlight that sepsis occurs within a context, and we need to be looking all the way through from prevention through that to early diagnosis, management, and all the way through to looking after the children, but also their families, because if we leave the families out of this, we're going to miss a vast number of opportunities to actually make a difference to sepsis outcome. But I also want to put that into a little bit of a context, and as you've heard, I come from Africa and obviously have a little bit of a bias in terms of the needs of Africa. First of all, is to look at just the mortality rates that we are looking at when we look across the world. And you can see the red areas in Africa here. But this data, the upper section shows data 10 years prior to what happened 10 years later by 2019. Firstly, you can see that there's been a very rapid improvement, and that's huge grounds for congratulations to all those that were involved in the process. But what we're now seeing is that when you look at the detail on the lower section of the slide, you can see that it begins to look a lot more granular. And again, what that means is we need to stop moving away from looking at big regions to actually looking at what's happening in sub-regions. And that's true in both rich and poor countries, because even rich countries have areas of those communities where the mortality and disease associated with sepsis is similar to those in poor countries. I do want to highlight the fact that in Africa, because of issues such as displacement, and something like 3% of the entire population is displaced at the moment, we have outbreaks of sepsis from conditions such as diphtheria. It's just highlighting some of the numbers of cases seen over the last in 2025, and also conditions such as cholera. Those are entirely preventable, but there are significant causes of mortality related to sepsis, and we need to be thinking about how we deal with the instability, the conflict that actually leads to those situations. And once again, these charts here highlight just the impact of refugee camps displacement on the outbreaks of infections that in turn lead on to sepsis. So we're going to deal with this in a global context. We are actually going to have to address some of the issues around conflict and displacement. I've also just shown some data here which looks at isolation from, or positive isolates from blood cultures from patients with sepsis. On the left, you see the profile seen from patients from rich countries, and on the right, you see the profile from patients from poorer countries, particularly in Africa. And what I really want to highlight here is the fact that actually there's a massive difference in the particular organisms that are affected and causing the problems here, and in the underlying pathology, because obviously one of the issues that drives the problem in poorer countries are conditions such as HIV, malnutrition, and those are not the things that are the major drivers in the richer countries of the world. So we're going to have to focus on what the particular pathogens are. Of course, knowing what the pathogens are, knowing what treatment we need to do, goes nowhere unless we understand how easily patients can access healthcare. And on the left here, you have some data from 2018 showing areas of Africa in the situation. The green shows parts of the continent where people live within 2 hours travel of the nearest hospital. The orange shows areas where there's more than one person per kilometer who would take more than 2 hours travel to the nearest hospital. So imagine that. If we're talking about large populations who live more than 2 hours away from any healthcare, and transport is probably on the back of a motorcycle, the intervention is going to have to happen at community levels and hugely at preventative levels. The diagram on the right actually highlights the proportion of the population in Africa and different countries living within 2 hours travel. What I'll also highlight is that when we looked at this in Cape Town some years ago, there is a massive difference between what happens during working hours and out of working hours, which I will remind you makes up 3/4 of the working week. So we're going to need to identify the pathogens and the populations, look at prevention, and look more carefully at access to health care. I really want to highlight the concept that pediatric sepsis is actually failure of the health system. It's failure of prevention. It's failure of early and effective treatment of infection. And also, there are many aspects where there's failure to support children and their families with the consequences of infection, which is not just mortality. The morbidity may be huge and lifelong. And again, if we're going to deal with it, as highlighted in this paper by D'Souza and others, we're going to have to look at the policy and public domain, clinical domains, and in the whole area of society. And I think there are many areas where we need to be reaching out to society to actually address those. It interests me that when we look at the CDC recommendations for hospital sepsis, a vast amount of the input in those documents is not on clinicians. It's actually on training the administrators, the managers, the support teams on what is actually required to actually make sepsis care happen effectively and efficiently. And I think, again, that's part of the lessons that we've had to learn, is to move from just looking at the clinical things through to looking at the systems. Tim Baker has already alluded to the issue of basic critical care. I know there are programs from the WHO and from the essential emergency and critical care programs. It's interesting that we can make an impact at that level, and that's already been highlighted by the work that Tim and others have presented earlier, showing that hospital deaths fell by 31% in an area in Tanzania. But again, interestingly, that involved the government, the clinicians, the managers, and the whole of society. And a huge part of that was actually education. A large piece of what they did relied on the fact that they were able to achieve significant improvements in education of all the personnel involved there. One of the areas that I think is a huge gap is what happens when we leave, or when patients leave hospital after an episode of sepsis or even severe infection. And this is some work that Matt Vierens and others have done, showing that when you actually go to the health system in some countries in Africa, you find that large things that are recommended, such as post-discharge risk assessment, scheduling of follow-up referrals, etc., are simply not happening at multiple levels in the health system. And again, that's an area where we're going to have to focus on and start putting input. There's a part of me that says we should not be surprised if an environment that makes children get sick makes them get sick again when we send them back into that same setting without actually addressing those issues. And if we're going to address those issues, we're going to have to find ways of bringing families on board. That's at multiple levels in the health system. But one of the things that happens when a child comes into hospital is you actually have parents and families as captive audiences. And we need to use that opportunity to see how we can provide the training that enables people to make a difference when they go home. Finally, there's some really challenging work that has come out of India where they looked at tuberculosis and found that actually programs that looked at the families from which TB arose and provided nutritional support to those families could have profound savings in terms of the costs of infection, the costs of disease over time. And I think we really need to be thinking about what do we need to do to the families of children who get sepsis and how do we support them in ways that may change outcomes. And so, in conclusion, we have to look at the entire spectrum. Clearly, if we're going to do that, we need focused data collection. But I think our research focus also needs to extend beyond the acute recognition and right out into issues which happen in the community and post-discharge from the ICU, from the hospital, and from the health system. So thank you very much for your attention.
Thank you so much, Andrew. And I'm so pleased representing an organisation that supports people affected by sepsis that you talked heavily about recovery and what can be done in the recovery and the post-sepsis period. So hopefully that will generate some questions. So our final speaker is Alegnta Gebreyesus Guntie, and she's going to talk about why Ethiopia decided to lead the effort for the World Health Assembly resolution on integrated emergency, critical and operative care, and on the upcoming global strategy on eco. Now, Alegnta is an emergency physician practicing health diplomacy at the permanent mission of Ethiopia to the UN office in Geneva. She's previously coordinated the Africa group in Geneva with big contributions in international instruments in health, negotiated several WHO resolutions, and played a crucial role in advancing regional interest in multilateral health fora. She's had lots of leadership capacities. For example, she was director of the Emergency, Injury and Critical Care Directorate in Addis Ababa and chief of patient flow and quality improvement at St. Paul's Hospital, Millennium Medical College. So very well placed to please tell us, why did Ethiopia decide to lead on eco?
Thank you very much, Ron, for the very kind introduction. It's my sincere pleasure to be here. Very pleased to be here. I think it's a very interesting question again, and also very pleased to be here as the issue of sepsis is an issue that spans over the life course. That is very, very critical to the agenda of newborn child and maternal care, which is also a key priority to Ethiopia. So taking all this into consideration and taking the lessons from the COVID-19, which really showed the gaps in the capacity in emergency, critical and operative care, we strongly thought that it was time to integrate efforts, build on what has been achieved through previous resolutions of the World Health Assembly, and also keep the momentum to really galvanize and have a collective global effort to push the agenda forward. So with this, it could be seen from the WHO 76.2 resolution. It really tries to connect the dots really trying to strengthen the universal health coverage, the health system strengthening, and also connecting that with the public health protection from public health emergencies and the health security piece. So this integrated approach, integrated acute care continuum sits in those both sides, and strengthening that the integrated emergency, critical, and operative care will undoubtedly improve meaningful outcomes in patients' lives and avoiding mortality and morbidity. We've also, from our national and local implementation of such initiatives and the integration of such different services, it's not they are not actually different, but from the integration aspect, we've seen the effectiveness, the cost effectiveness of such interventions. So we thought it's such a good opportunity to put it in a policy document, a resolution document that would send a clear signal for all stakeholders to collaborate on such issues, highlighting the specific elements that could be taken by governments and specifically by the WHO. So with this, we also think that it's not only about global advocacy, but having a concrete action to follow through and have that implementation in countries, not only at the national level, but at the subnational and at the facility level, would really move the needle forward. So it starts from calling for global action for all stakeholders to strengthen the planning and the provision of the integrated emergency, critical, and operative care as part of both the UHC as well as the health security component and the population health needs. This being very much centered on the primary healthcare approach, and also having specific provisions or specific mandate to the WHO to support countries in building capacities, in having the necessary collaboration, and also preparing the global strategy and action plan that would guide the work forward. So the countries are also expected to have the policy and planning level, the governance structures, and also the financing piece, and the very critical element of sustained capacity building, the integration of this continuum, the different components of the continuum in a sustainable manner. So all in all, these have been one of the reasons why we highlighted and took the leadership role in facilitating the endorsement of the resolution. We're very excited to have the upcoming global strategy. The World Health Assembly will also be considering that. Hopefully, finally, after the adoption, we're very excited to also join hands in the implementation, and I would like to also take this opportunity for all who are listening and watching to join hands in the actual implementation of the global strategy and action plan. Thank you very much, and over to you.
No, thank you so much, Alegnta. That's a fascinating insight and a huge uphill struggle. But I'm going to start with you, if I may, because I want to encourage more questions into the chat, and then I'll move to the questions from the chat. But I'd like to take you back, actually, back to being an emergency physician in Addis Ababa. And we've heard Andrew talk and present around the long transit times in Africa, the poor access to healthcare, the inequality and equitableness of access to preventative measures. How, in your role as an emergency physician, did you see that impacting the human side of the impact of that on families and caregivers? Sorry, you're muted.
It's a very interesting question. Oftentimes, when we're dealing with policy issues, it's very important to bring the human element as well. And having served as in the frontline clinical role, people come to the emergency or at the first point of contact, very frustrated, very worried, concerned, and unsure of what's going to happen. And it entails a lot of anxiety, a lot of issues, not only health, but economic, social, and other issues as well. So a holistic approach and a timely approach for care delivery is quite essential. And the more equipped, the more ready the frontline workers are, the better the outcome. And the more, not only that, but also the more connected the system is, the better outcome, because it's the things don't only happen in the emergency room, or they go beyond. So the referral services have to work properly. The capacity for intensive care units, the operative care, the anesthesia, the rehabilitation, the palliative care, all comes into play. So it's really a system issue. And from the a provider perspective, not having those sequential and very important elements in place, and a very not a well-working system really adds to the frustration of the providers as well. So your hands would be you would be tied. But the good thing is with sustained planning, with deliberate planning, with deliberate capacity building, sustainability of efforts, and having that political will and support as an overarching way, and ongoing support as a system, we can really make a difference.
Yeah, thank you so much, Alegnta. And I'm glad you mentioned how frustrating it can be for the health professionals, and I'm sure upsetting. I mean, I think it's an important point to get across, because there's people in the audience from higher income countries with more integrated healthcare systems. So just from the chat, I've seen people from Las Vegas, from Qatar, from Oman. You know, I know, for example, that in Qatar, the median time from an emergency call to an ambulance arriving at the home is less than 10 minutes nationally. So these are going to be alien concepts that people simply can't access healthcare. And as Andrew said, came in on a moped. And Andrew, have you observed similar to that? And second question to you, Andrew, and sorry to be going in reverse order. You thought you were going to get a break, but my charity works with a couple of pairs of genetically identical twins, where the twin who had sepsis as a baby is far less physically able, has reached far lower levels of educational attainment than their genetically identical non-sepsis twins. So I think firstly, your reflections on what Alegnta's just said, and secondly, do you think there's any way we can measure, because it would be really powerful for politicians, the impact on children not reaching their potential?
Okay, so that's a whole set of things, Ron. But
yeah. Put you on the spot.
I mean, I first really want to highlight this issue of access to care, because you can start at one level from saying, from when I decide I want to get help to when I get help. And often we're talking about 2 hours. The reality is that even in metropolitan Cape Town, if you live in a peri-urban area and you have to get to help at 2 a.m. on a Saturday night, it's going to take you a long time longer than 2 hours to do that, because of issues such as access to transport, safety of transport in the environment. So I think we underestimate just how long it takes people to get to healthcare services. There's another thing which is part of that, and that is actually asking people who arrive at a hospital needing care for sepsis, how many times they've actually seen a healthcare provider within the course of that illness before actually getting there. And there's a whole chunk of patients who've been seen on 3 or 4 occasions before they end up arriving in hospital with a crucial thing. So the actual delays are substantial. And I have to ask, you know, it's one thing thinking about how do I seek help if I can just pop into the local place and be seen straight away, versus I have to give up a day's income, find someone to look after my children, spend an entire day sitting in a waiting room to be seen by someone I don't particularly trust. And those are the extremes. And I think we just need to highlight those. Your second question about the impact of, you know, actually getting to your potential. I think there's very little doubt that children who are liable to sepsis and there's a much higher incidence of sepsis in lower income settings, both in rich and poor countries, are already vulnerable to not meeting their potential for multiple reasons. And then the moment that you've had a severe illness and need additional support in terms of physiotherapy, occupational therapy, additional support, and perhaps have been identified as having an underlying condition, access to long-term care and support makes a vast difference on their potential outcomes from there. So I don't know if that answers your question, but I think it's a hugely important thing. And we spend so much time focusing on the acute that we sometimes miss the implications of getting someone through a sepsis illness but not in perfect health is that we now have a long-term commitment to try and deal with someone. And of course, if you've suffered disability as a child, that is a lifelong, decades-long disability that needs to be addressed.
Yeah, thank you, Andrew. That did answer my question. I think this is really food for thought, isn't it? We need to begin to try to quantify this and evaluate how we can improve it. So moving to questions from the chat, to start with Teri, if I may, there's a question from Naoki Matsuda, who says that we still find it challenging to diagnose whether a child has an infection, of course, and are there international differences even in the interpretation of initial vital signs? And I guess I'd just add to that, if there are international differences, how can we address this?
That's a fantastic question. I think that one of the things that as an academic and research and data-oriented community, we're often uncomfortable with is the incredible context dependence of what we like to call evidence with a capital E. And we like to talk about the need to be evidence-based and the need to be evidence-informed. And yet there is a weakness at the foundation of that concept, which is the context dependence of both diagnostics and therapeutics. And there is there's a wide range of things that contribute to that. One of them certainly is, for example, if you practice as a clinician, when you're considering a child with an infection, your behavior, your response, your level of concern is completely transformed by an accurate understanding of the vaccination rate in the community around you. The choices that you make about how to best treat and support that child and family are entirely different based on your understanding of their social context. So it is an excellent question, and there's no set of international guidelines that will support every child and every health worker in every situation. One of the things that we try to do at WHO is make these concerns, these questions visible, and to support especially subnational planners, not only national level policymakers, but subnational planners with a framework that outlines the decisions that need to be made in order to have an effective approach to caring for people with sepsis. That doesn't mean that we can tell people what is the right decision in all cases, but I think that it can be very helpful to support subnational planners and national planners with these kinds of frameworks to say, listen, if you're going to have an effective response to sepsis, you need to account for all of these components. So that is how we usually approach questions like this. I don't think we're ever going to have a single set of international guidelines. And if anything, we push quite hard. One of the key work streams, for example, in the Acute Care Action Network is an anthropological evaluation of care-seeking behavior. Because as we heard already from David, this really transforms. You can have the greatest resources in the world available at some location in your health system. But if you're not attending to the way that people make decisions about care seeking, you will fail. Similarly, at the other end, as has been mentioned, very simple rehabilitation interventions can absolutely transform by an order of magnitude the cost effectiveness, for example, of hospital-based interventions such as surgeries. So the idea that a policymaker is making a decision about whether a certain surgery is cost effective or not, as if it's a binary, is really an inappropriate way of talking. And so these additions that we've all talked about today, I think that's a common theme, is that there are these additions of processes and instruments that guide where you put your attention when. And those are absolutely transformative in terms of the effectiveness, in terms of the cost, in terms of everything that we do to care for people with sepsis. So I hope that answers the question, and happy to follow up if needed.
Thanks so much, Teri. I mean, it certainly did to me. So sticking with questions from the floor, and Tim and David, I haven't forgotten about you, but I'll come back to my questions unless any arise. A question from Melissa, actually. It's from Martin Johansson, who asks, what are the major obstacles to implementing BEC and EECC in low-income countries? There's enormous benefits, so what hinders progress? And I'd just sort of add to that, there must be obstacles to medium fidelity simulation training in low-income countries in terms of logistics and resource and protecting equipment. And how do we mitigate those? How do we get over those?
Thank you, Ron. I would say absolutely right. There are a lot of difficulties for implementation. I was just saying a few days ago that we often think that the plan is the plan of the thing you're going to do or you're going to implement takes more time, but actually we need to spend more time planning about implementation details. And these kind of things are the most important. But I think the key message that I want to share with this audience is that implementing this in low and middle income countries is way easier than what you're thinking. So these materials are open access. We've shared the site. There is a wide network of basic emergency care facilitators around the world. And as time goes by, we are finding it a lot easier to implement. So often what's harder is to do the first course because a local team doesn't know what they need, doesn't need how to protect equipment or where to get it or what's the schedule or how to organize things. But once the first training happens, we've seen it's easier to carry out. We have a very successful experience with one country, with many countries, but I'm just going to share one in the Americas region that just did one course, and then over 2 years they've done, I can't remember the exact number, but they've trained over 300 BEC providers, and they've just developed their model of doing things. This is not a specific model, but each country, each government, each group that wants to implement the basic emergency care course, following the package that the organization is sharing with them, they have to just define their own specific implementation strategy. But there is help, and in the email I shared, we'll be welcome to respond to any additional questions for this.
Thank you so much, Melissa. I'm sure that's very helpful. David, you talked about lived experience and using lived experience to inform the planning in Malawi. I wonder, and this is putting you on the spot, but have you got any specific examples of that? Or if not, you touched on some of the general themes, but what were the most important themes that influenced your decision-making and that of your colleagues?
Yeah, hi, thanks. So I think throughout the research cycle, we're really lucky to have the opportunity to engage with lots of patients and communities, and indeed they include women and families who've had sepsis. I think in terms of the specifics, actually, most telling perhaps is some of the work that's gone on after the trial has finished, actually, and the work that is being led in MLW by the teams going back and speaking to communities and exploring how, with these trial findings, we can really implement at scale and sustain the findings. So, for example, you know, the control sites have come on board, but this is outside a trial context. You know, there isn't any trial resource behind it. So how can communities work with hospitals and providers to ensure that they can sustain and maintain the interventions? Yeah, and just to, I guess, highlight the other elements that particularly came out of those patients' stories. For example, the needs to empower, integrate respectful care. They actually have led on to specific interventions that we're now trialing in large cluster randomized trials, being led by Linda Nyondo-Mapando in Malawi, who's thinking how she can support healthcare workers differently to actually empower patients, and those same patients were involved in developing those specific aspects of the intervention around those key features that will be applied in antenatal care. This is the enhanced trial. So I think those were sort of specific areas that came from patients. They then co-developed the interventions that are now being, as we speak, implemented as part of the enhanced trial by my colleague Linda.
No, thank you so much, David. And I have no doubt, having witnessed how you engaged with the health professionals in Malawi designing FAST-M, that you listen hard to those with lived experience. So that's fantastic. Tim, so this was just my reflection, and it probably exposes my naivete, but I was surprised that you mentioned in the Achios study that the 7-day mortality in critically ill patients was, to my mind, only 21%, which, you know, is not dissimilar to, for example, intensive care mortality in my country. And you also presented the Swedish data. I mean, obviously there's huge resource differences, but is this simply because of the differing definitions of critically ill between countries, or are we actually all in the same boat?
I think in some respects we are all in the same boat, in that humans are humans, and when our physiology becomes deranged because of sepsis or because of another cause of critical illness, then we are at risk of dying. It's often the case that places with more resources will also have a different case mix. So some of these cross-country comparisons are a little bit tricky. Comparing Sweden and Malawi, for example, we did one study in both those countries, and mortality rates were very similar, but the population in Sweden, the median age was over 70, whereas in Malawi it was in their 30s. So the patients are very different. The underlying epidemiology is different, the underlying causative organisms in sepsis are different, and then the resources for providing care are different. I think the outcomes of 20% mortality I would regard as high because of the very kind of broad criteria we used for critical illness in that study. If we look at ICU outcomes in low-income countries, in settings like Malawi or Tanzania, they're more over 50% or even higher. So ICUs are a very particular subset of critical ill patients, likely the absolute sickest ones, and with very high rates of mortality. I think it's more useful all over the world to look not at the care we're providing as in an ICU, but the patient physiology itself. And when a patient has a life-threatening condition, then they already have a 21% risk of mortality. So these are high-risk group of patients who we can identify, and then we can do the life-saving foundational care as described in EECC.
Thank you so much. That helps me, and hopefully it's helped other people who are similarly naive to this as me. There's a quick follow-up question for David before we begin to close, from Nala Suleiman, asking how the project is financed. I mean, I would assume that's through the Malawi Liverpool Wellcome Research Programme, but is that correct, David, or not?
So the original trial was financed as an academic study by a consortium of funders, which was Wellcome, Medical Research Council, and NIHR, which was using UK overseas ODA funds through UK aid. The follow-on work and implementation is now being funded by the Ministry of Health with the support of other global partners like WHO, UNICEF, Beginnings Funds. And we also implemented in non-government facilities such as church-run mission hospitals. So again, they have a separate funding structure. In terms of the support that was offered, we had an implementation approach that supported healthcare providers to change their behaviours, but we were not funding large-scale resources for the hospitals. We weren't providing drugs or transport or staffing or anything like that. That all came through the health system itself, and there's a formal health economic analysis, which isn't yet out, but should be, to give more information around that.
Thank you so much. So that's concludes the questions from the floor. I've been granted permission to run for an extra couple of minutes. So I'm going to put everyone on the spot now in just sort of a small number of words. Is there one thing that you would like to wave a magic wand, to use a British expression, to fix? Now, I'll kick off just while you're thinking frantically. I would like to see equitable access to diagnostics close to the patient would be my one. So would anyone else like to go? What's the one thing that would help you and those people you serve?
Perhaps if I may.
Of course.
I would like to see transformed health systems that deliver timely access to high quality and integrated eco services without financial hardship.
Thank you. Can anyone build on that? I mean, Teri, I would imagine you'd reflect that, unless you have anything else that you would like to see.
No, I think, I will almost always defer to Alegnta when she said something. I've been doing that for many years. So look, the one thing I would say is integration. We are not as humble nor as disciplined as we need to be. And the cost of that now is become unacceptable. So we are doing so many things in parallel. We are duplicating expenses. We are behaving in inefficient ways. And it's not as simple as principles that we care very much about, like listening to countries, because no one country on its own can set a shared North Star for action and communication. But we really just have to, all of us, partners, countries, WHO, governments, we really all have to start being more disciplined about understanding whether we are doing redundant work that could be better defined and limited, that would be complementary and allow us to go further together. So I know that sounds quite abstract, but if we really stop ourselves with every single thing that we think is a good idea and ask, is there someone in the system around me who can tell me if someone's already doing this? Is there a way that I can do one piece and allow someone else to do a different piece? And a lot of that does have to do with deferring to government leaderships. Governments are very particularly positioned to help us be effective integrators. But from the top down, from our financing, from our ways of evaluating data, from our ways of implementing, we are doing way too many things in a redundant way and failing to integrate. And we really, in the current global health context, people are dying every day because of this failure. So that would be my one thing, that every time you think you have a good idea, we stop and ask ourselves, who else can I do this with? And what part of my great idea should I give up? Thanks.
Fantastic. Thank you. Melissa, David, Tim, anything to add to those words of wisdom? Okay. Tim, you might be.
Very, very briefly, I think this focus on equity and the basic things, just make sure that we're always providing the care that the septic patients or critically ill patients need, the foundational bit. If we get that in place, then we can build on that and we'll have most population impact.
Yeah, 100%. Melissa, were you going to say something?
Yes, thank you. Well, building in Alegnta and Teri's comments, this system level transformation is really needed. And just to do what Tim mentioned, I think it is essential that every facility ensures that the first provider that comes and that has contact with the patient has all the tools they need to recognize and act early on critical illness. Otherwise, it doesn't matter if the system has all the resources, we'll still fail.
Thank you so much. And I would like to thank, on behalf of everyone listening, on behalf of the Global Sepsis Alliance, all of our panelists. We've had expert speakers from really all corners of the world, and we've heard about how we can tackle ECO care pathways in mother-child settings. I'm sure it's been great food for thought for anyone listening, and I'm sure those contributing are more than happy to answer any follow-up questions. So thank you so much for listening.